So I mentioned to you J. Silas Cohen, or J. Solis Cohen, who was the first professor of laryngology. The English translation of the first text on direct laryngoscopy, which Kirstein called otoscopy, was dedicated to Dr. Cohen. And he was one of 5 physicians in his family, all of whom had connections to Jeff, actually. And after serving in the Army of the Potomac, he was in the Civil War. He wound up getting involved with laryngoscopy. And I like the jewel bucket here on the faceplate here, and Kirstein doing direct. But Kirstein talked about bringing the head forward so that the mouth basically came into a position that aligned with the axis of the trachea. So the body must be placed in such a position that an imaginary continuation of the laryngotracheal tube would fall within the opening of the mouth. So this gets back to the reason why people come in respiratory distress like this. It's because your trachea is oriented in your upper thorax forward. So by bringing your head forward, you align this axis, you maximize upper airway volume. So, that's, thank God, too, because as we age, our head comes forward. Imagine if as we aged, we went like that. And we all became epistotonic. It would be terrible. We'd all basically strangle, to death. But I came up with this concept that we should bring the head forward until the ear is aligned with the sternal notch. And I came up with that because I got frustrated with listening to people tell me, put the patient in sniffing position. And I'd go, huh? Sniffing position? It's, so I think our terminology is very important. I used to say optimal external laryngeal manipulation. I now say bimanual. I used to say sniffing position. I now say ear to sternal notch. But here's Kirstein again. Look at how intimate a procedure laryngoscopy was back in the 1800s. But he talks about the forward inclination of the body and how it reduces the muscle tension in the neck. So Jackson, for those of you who don't know, perhaps the most famous physician of the 20th century, came up with skull and crossbones and poison labeling, and actually convinced the United States Congress upon 35 trips to Washington that all caustics should be labeled and poison should be labeled. The rest of the world followed and saved millions of lives, directly responsible for training 4,000 physicians. But he talked about the access of the trachea as well, and the importance of positioning. And here's one of his drawings. And again, notice the amount of head elevation. So he talked about at least 10 centimeters of head elevation. And when you go up to the OR these days, and Dr. Osborne just arrived. For those of you who don't know Dr. Osborne, Irene is a long-time friend of mine and an incredible resource you guys have here at Sinai. We were actually out at dinner last night discussing the fact that you should play well with your anesthesia colleagues. And thankfully you guys are lucky to be able to do that. But I highly recommend you have an airway play date with Dr. Osborne, who has invited me to do the same. And I've enjoyed it. But here's a picture of Chevalier Jackson's crypt, which I visit on occasion because it's right near my house. And but his positioning, he called it the raised, extended, correct positioning. And the ear to sternal notch, I think if Jackson and I could have dinner, he would go for the ear to sternal notch line. But this is labeled HB. His colleague was named Herbert Boyce, and he called it the Boyce position. But what he did was he would have this table that they would drop the back of the table down in the operating room, and then an assistant would grab the head and lift the head higher. And the reason why I point this out to you, and here's some more imaging of actually Bannister and Macbeth in 46. So at the turn of the century, or not that much later, 1910, 1920, as positioning was getting really understood by the ENT docs, along comes this nascent field of anesthesiology in the 40s and 50s, and they comment on Jackson, and here you can see they're using a straight blade. But what happened somewhere along the way was we came up with the foam donut and 4 centimeters of head elevation. And I don't know what that's from, but it's way inadequate. And as we have gotten bigger, we need to do a lot more head lift. And I mentioned to you that the reason why everybody brings their head forward is to maximize upper airway volume. So here we have, with a tracheal tube, I walked over to radiology one day, and like this, you can see my airway is somewhat obstructed. By the way, the other patients were like, you go first, doc. And I'm like, thanks. But leaning my head forward, you can see this upper airway really opens. And it's no mystery why people bring their head forward, because it maximizes upper airway dimensions. So I mentioned to you that somehow we got distracted with this idea of extension facilitating, airway patency, and it doesn't. So here we have jaw thrust, and we pop the jaw out, and it really opens up. But look what happens. This is submandibular lift, but watch with just cranking the head back, the epiglottis does not come off the posterior pharyngeal wall. And in fact, with jaw distraction, bringing the face plane parallel to the ceiling, you really open up the airway. But this helps too, and on occasion I do that to assist my residents when we're bagging. But this atlanto-occipital extension does not open up the airway at all. So my son is 16 and a willing participant in my airway education endeavors. I went and gave a recent grand rounds out on Long Island. He played hooky, and he came up to this course with me, and I got to scope him actually in front of everybody, and he was totally into it. All I had to do was bribe him with a dinner at Peter Luger's on the way out, and he was totally on board. Notice what happens with your head straight. Your mouth opening and your thyromental distance are minimized. And as you bring your head forward, basically, the jaw can distract significantly more. This opens up. And the reason why this is so important is because this is our displacement space. And this is true with the glide scope, it's true with the LMA, it's true with the laryngoscope. Atlanto-occipital extension is bad. You decrease space, you make it much tighter to insert these devices. And it's kind of neat that this fellow on the other side of the world, a guy named Keith Greenland, has now been validating this with MRI, and basically has found that the higher you lift the head, and then if you have the face plane parallel, that you optimize the patency of the airway. And he's done some really interesting work looking at the MRI piece of this. In 1998, a fellow by the name of Steve Zeitels, who is now the chair of laryngology at Mass Eye and Ear, for those of you who watched the Oscars, well, it wasn't the Oscars, it was the Grammys, Adele, Dr. Zeitels operated on Adele. But Dr. Zeitels may be the world's foremost laryngologist in terms of voice stuff. But he's up in Boston, and he gave this lecture in '98, and I heard it, and I thought, wow, that was pretty cool. What he recommended was lifting the head much higher and flexing the head on the chest to expose the larynx. And this was counter to that concept of cranking the head back. Well, so I called him up, and I was able to reach him, and he goes, well, come up to Boston. So I stay at his house, and in the ground floor of his Back Bay brownstone, he has instruments from the 1800s and early 1900s from Jackson and others. And the first case that morning was a 400-pound Massachusetts toll pipe collector. And this man had laryngeal polyposis. And he spoke like that, and his larynx was filled with polyps. And they waddled him into the OR. And he's this huge guy. He literally walked himself in. A huge man, kissing thighs. I mean, we're talking big. A neck, scary. And Dr. Zeitels turns to the anesthesiologist and says, you have muscle relaxants? And he goes, yes. Put the man to sleep, push the drugs. And the anesthesiologist looks at him and goes, I really don't think that's a good idea. And they have this whole debate, and it ends with the anesthesiologist saying, if you need my help, I'll be outside. And, Dr. Zeitels' attitude was, it's my larynx. Now, he to be fair to Dr. Zeitels, he had already scoped this guy. He knew what this man's larynx looked like. And in fact, there's a fellow now at Yale, Irene and I know well, Will Rosenblatt, who believes that everybody before they go to sleep should have fiber optic endoscopy to assess the airway. And if you go back actually and look at Kirstein, look at Jackson, they all talk about if you're going to do direct laryngoscopy, you want to put a mirror in first to evaluate the airway. So in a way, what's old is new. But in the 1900s, they recommended mirror before direct. Zeitels clearly had scoped this man and knew the airway. The bottom line was they pushed the drugs, they dropped the head of the bed down, and this 400-something pound man, his fellow lifts the heads up, and he's wearing my head-mounted camera, and we see the cords come into full view, and he goes, think, and he goes, Rich, can you tell him we're about to start? I'm like, but it was just a classic, and Harvard and guys with fat heads. But anyway, but Dr. Zeitels is a remarkable clinician, and so he wrote this wonderful paper on extension, 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 flexion, and what he called flexion, flexion. But I believe that face plane parallel to the ceiling is the way to go. This was a wonderful article that I only recently discovered by Kitamura, which looked at the mechanics of this. And this person subdivided the anterior obstacles to laryngeal exposure and the posterior obstacles. And what he found was the higher you lift the head, caudal and upward movements of the mandible and tongue base increase the distance between the anterior and posterior obstacles, and an increase in the submandibular space, which gets back to head forward positioning or head elevated positioning, really improves laryngeal exposure. So trying to sort of define, especially for the novice innovator, the best way to manage the airway from a mass ventilation perspective, Element, GlideScoop, Direct, I believe ear-to-sternal notch is the way to go. And it doesn't matter about age or size. This is a picture of my 2-year-old, a large occiput. By the way, she's now 15. If you blink and this stuff happens. But large occiput here, ear-to-sternal notch. Every sheet and pillowcase in the place in the ER I ramped up for this person. And, you know, this person's not comfortable breathing like this. There's tremendous advantages from positioning perspectives in terms of ramping the morbidly obese. I got involved with a group out at Stanford doing this, and this has now become standard. In fact, there is a course called Bariatric Life Support. I kid you not. You know, America leading the way here in the bariatric life support. Well, you know, the Germans and the Brits are catching up too, but bariatric life support, and they have now made ear-to-sternal notch alignment a common way to optimize positioning. And, you know, it's not only about the mechanics, which, as I mentioned, Dr. Greenland has done some work on. It's also about, you know, well, there's laryngeal exposure, but there's also pre-oxygenation and the efficacy of pre-oxygenation. But I did this study using angle finders, and the higher I lifted the head, basically, the more laryngeal exposure. Anyway, I won't go into those details, but let's keep moving here. So I got a phone call from a guy named Hubert Schmidt from, I forget if he was Austrian or German, but he had been combining head elevation with bimanual laryngoscopy. And what was really neat, you know, so he started out with 1,500 cases, wound up with 21 epiglottis-only views, and then by combining these two techniques, wound up with 2 epiglottis-only views. And, you know, what's fascinating is, like I say, there's nothing new under the sun. Chevalier-Jackson, 1922, if the anterior commissure of the larynx is not readily seen, the lifting motion and elevation of the head should be increased, and if there's still difficulty, index finger externally on the neck to press the thyroid cartilage. So this is exactly what I've been recommending. Chevalier-Jackson was a weird guy. He had active tuberculosis. He stood about 4'11". 1/3 of his life he had hemoptysis, and he would be out writing his books. But he didn't believe in shaking hands because it spread disease, so he took to bowing. And in the 1920s, he had this very peculiar notion that women should be physicians. And so he was actually one of the pioneers of MCP, Medical College of Pennsylvania, that promoted, you know, women in medicine. And he had this very strange idea that, you know, fascism and racism and sexism basically should be discarded. And that was in a time period where not many other people held those opinions. But really a remarkable guy. So let's take a look at bimanual laryngoscopy with head elevation. I'm in my cadaver lab, and the bodies here have been specially prepared, venous drained, arterially flushed with isopropyl alcohol, so they're mobile. I'm demonstrating bimanual. We have corniculate, cuneiform, the interrytenoid notch, our posterior cartilages. We get the glottic opening, and, you know, the view is fine, and yes, I know where the hole is, and I can drop the tube in. But what if you want to see the anterior commissure? Well, you lift the head much higher, and I'm going to do that in a second here, bring my hand around under the occiput. There's the vague hole of the esophagus. But watch what happens when we do head elevation here, like so. A full span of the larynx.